Thank you, Brian. I'm also known as a person who made Molly lose bingo last night because I talked to her too much. But anyways, I just want to update you on arachnoiditis and Syringomyelia and just the inflammatory changes that occur. And a lot of this research was done by some of the students in our labs at the NIH. Arachnoiditis arises from inflammation, and inflammation is if you've ever had an infection or something like that, that's an example of inflammation. But you can, with arachnoiditis, sometimes the inflammation comes from trauma, and you have red blood cells released, and they're irritative, and then they cause inflammation. Sometimes you have infection like meningitis, but what they all do is this area in here between the dura and the spinal cord called the subarachnoid space. There are usually a few bands there, but more and more fibrous tissue builds up there, and it glues the dura, to the spinal cord. And some people call that adhesive arachnoiditis, just like adhesive tape. And the problem with that is it closes the spinal fluid pathway. It causes syringomyelia. It affects these blood vessels that impair blood flow. And it tethers the spinal cord to the dura, because every time you put your head up and down, the spinal cord moves. But if it's tethered, the spinal cord can't move, and that traction is not tolerated very well by the spinal cord. All right, so what we see is pus, redness, little heat to tissue when there's inflammation. But what underlies that are these cells here. And the cells respond because they want to form a barrier. They want to keep out bacteria. So it's a preservation response. And so you'll get these white cells that are recruited from the tissue, and they go out and fight potential bacteria or whatever. And then there's some bleeding because of irritation of the surface. And there's fibrin released. And fibrin is a component of the blood. And fibrin gets these cells called fibroblasts that come, and it walls the problem off to keep it away from the healthy tissue. But the problem in the subarachnoid space is the walling off process causes this fibrosis, which is called arachnoiditis. And so it's a healthy response, but it ends up causing a problem. If you interfere with the blood or with the CSF flow in the spine, or if you tether the spinal cord to the dura, you can develop a syrinx, shown here. And the syrinx affects the inner part of the spinal cord. That's called the gray matter, and that affects the nerves that go to the muscles, so you get muscle atrophy. Later on, it affects the nerves that go to the legs, and then you'll get spasticity. So you won't lose muscle substance, but your muscles will be tenser. You know, they'll jump, you'll need baclofen and drugs like that. As far as arachnoiditis, it comes in different forms. You know, there's arachnoiditis light, and then there's arachnoiditis heavy. You know, so if you get a little bit of arachnoiditis and it's right under the lamina, you could see that if you did a laminectomy, the surgeon could go in and he could cut these bands, or she could cut these bands. However, if the arachnoiditis goes all around the spinal cord, you can see you're looking in here and you can't see the bands in front, so that's a much more difficult problem. All right, so people who have extensive arachnoiditis, not just a little bit, but a lot of arachnoiditis, and that usually comes from more significant problems. In other words, if you have very focal trauma, you might get just a little bit of adhesion. But if you have a lot of bleeding in the subarachnoid space, or if you have meningitis, which affects the entire subarachnoid space, you can have extensive arachnoiditis. And with the extensive arachnoiditis, you have worse outcomes because you can't visualize all the scarred areas during surgery. When you have a lot of scar, removal of the scar can injure the spinal cord. Everything appears white. It's very difficult to see the differentiation between the normal spinal cord and the scar, and you get indirect injury, and that could to the blood supply of the spinal cord, and you can get little strokes to the spinal cord. And then a major problem is the scar recurs because everybody has trauma, but certain people have arachnoiditis. So some people must have a genetic or other predisposition to forming scars, so you operate on them, and they're more likely to have recurrent scar. So I have Chantel, who's from the University of Iowa, and after graduating undergrad, she came and she's worked in my lab, and she wanted to study arachnoiditis. So we had samples of spinal fluid from patients before surgery, and samples of spinal fluid 1 week after surgery and 3 months after surgery of patients who had arachnoiditis and Syringomyelia. And we also had tissue samples from their arachnoid tissue, their scar tissue from surgery. And so Chantel's hypothesis was this chronic inflammation would lead to overaccumulation of the collagen and other scar components, like other scarring disorders of the body, because you can have fibrosis in the lung, and if you have that, you need a lung transplant. You can have fibrosis in the liver, you can have cirrhosis, so you can have pancreatitis with sclerosis. So you can have fibrosis anywhere in the body, but we're talking about arachnoiditis, which is fibrosis around the spinal cord. So we had 59 patients, we did 76 operations. And you might say, Dr. Heiss, that's more operations than patients. Well, some people had more than one operations. So you think you can do better the next time around. And a lot of these people had operations before. On the MRI before surgery, only 3 people had MRI signs of inflammation, but 24 of them had tethering. And post-op, no one had meningeal enhancement, and we're able to untether completely about half the patients. And that was at follow-up 3 months later. It wasn't early on. So then we looked at the spinal fluid, as I said, from before surgery, both the white blood cells and the red blood cells, as well as the glucose, which is a sugar, the Donald Trump cane sugar versus high fructose corn syrup type sugar, in the spinal fluid. And the white blood count before surgery, most people was very low, but a few people had some active inflammation going on. But 1 week after surgery, most people had some degree of inflammation with white cells. Some people had clear spinal fluid or very few cells, but some people had a fair number of cells because we have to open the arachnoid and some blood gets in during surgery. We try to prevent it. And then after surgery, most patients, the inflammation has waned by 3 months, but there are a few stragglers that still have inflammation and a few people who still have some bleeding that's going on, surprisingly, in the subarachnoid space. And the glucose levels were essentially the same, although it dropped a little bit on the week after surgery. So our conclusion was there was a cellular response to our surgery. It was worse about a week after surgery. It pretty much waned by 3 months in most people. And the way to prevent arachnoiditis was to not get as much blood in the spinal fluid during surgery, which is easier said than done. And there's a window during that period, like right after surgery, And we don't really know. It's sometime between 3 months after surgery, where if you used medication, you could suppress the inflammatory response and perhaps have less fibrosis. So Chantal stained for all these inflammatory markers, and you could see in the tissue, in the arachnoid tissue, there are all these markers of inflammation, even though the white count was low before surgery. And so she looked at both inflammatory cells as well as cells that make fibrous tissue. And you can see here that the inflammatory cells were relatively low, but the cells that induce fibrosis were upregulated in their markers for fibroblasts, and here are the inflammatory markers there. All right, we had a genius summer student who was tired of counting cells, so she decided to have a computer count the cells, and she wrote this paper, so she was able to work it out. She's from University of Virginia, so it's a lot. Work goes faster when you have the computer count the cells rather than counting them one by one. We wanted to see what kind of fibroblasts there were. The round fibroblasts are considered inactive, and the active fibroblasts are these ones that look like this. And most of the fibroblasts in the arachnoid tissue were active. So even though there wasn't any recent trauma, they were still active fibroblasts. So if you touch them, they will react. You know, it's like me not having coffee in the morning. And this is just showing collagen and fibrogen, just two proteins that the fibroblasts make. So our conclusion from this was that all the specimens showed increased extracellular matrix and fibrosis. We had a couple of patients who had increased white blood cells in the arachnoid, and we should have been clued into that because those people are most amenable to anti-inflammatories working. And then we still have some unanalyzed samples. They're just waiting. You know, it takes time to do this in man hours. But the fibroblasts outnumbered the inflammatory cells. Okay, so how do we make this better? You see what happens, so how do we make it better? Well, there have been attempts to improve on the situation, and there have been trials. And the condition that makes the most fibrosis around the spinal cord is TB meningitis. But thalidomide, which is a drug that reduces what's called neovascularity, that was tried in arachnoiditis. It didn't work. And TB meningitis, it was harmful. So that trial didn't work. Penicillamine, no better than control. This is a cancer drug. And some people recovered, with TB meningitis. So it seemed like that knocked down the inflammation, but you have to use it with TB drugs. Dexamethasone reduces inflammation in meningitis if given with antibiotics. And then there's actually an enzyme you can put in the spinal fluid. This has been used in India with satisfactory improvement in the majority of cases. So the same type of enzyme you put in the eye for certain conditions, in India you can give it off-label, and it can break up some arachnoiditis. Other drugs that people can use that have arachnoiditis, doesn't affect the underlying condition, but this is symptomatic relief. Drugs that reduce pain, like ibuprofen, gabapentin, which is Neurontin, antidepressants, You can use drugs to reduce CSF production, like acetazolamide. This is off-label. And you can use drugs to improve small vessel blood circulation, like vitamin E. But these are not approved for arachnoiditis. That would be off-label. And metformin, a drug that diabetics use, that potentially could reduce some of the inflammatory cytokines. And physical therapy can be used in people with arachnoiditis because you can build strength and function, and you can, stretching exercises can reduce scar formation. Okay, so what can we do? So what we've thought is make the trauma or make the surgery less traumatic. And if we could use an endoscope rather than open surgery, perhaps that would do so. Another way to do it, and this was from China, is to do a bypass of the scarred area. Just put a shunt in, or in this case, 2 shunts. And what they found is in 20 people that they followed just over a year, 17 people improved. So they say, well, forget it, we're not going into the scar area. You said there's potential injury to the spinal cord, we're just going to go around. But the problem with that is that this doesn't affect tethering, it just can potentially improve the CSF flow. What we've tried is using the endoscope to open the CSF pathways. And what we do is we do the surgery to cut the bands under the microscope, and then we go above and below with the endoscope, so we don't have to do as many levels of laminectomy. And it's very small. This is just slightly larger than a shunt catheter. And you can see that the forceps we use, here's a millimeter right here. So it opens to about 4 millimeters, but it's only a millimeter wide. I'm going to try to show a movie here. Worked before. Let's see. There we go. So this is just an example of arachnoiditis. You can see the scar. Here's some nerve roots here. Color's a little bit off. At least maybe it's better for you. But you see, basically, it's like you're a child and you just went into your grandma's basement, with all the spider webs. And that's where arachnoiditis comes from. Arachnoid, like a spider, So anyways, rather than using those tubes like they did in that Chinese paper, we're trying to break a hole through here just to improve the CSF flow. And this is in cases where pretty much you could do all the surgery you want and you wouldn't free things up. Your objective here is to open a spinal fluid pathway and try to accomplish what they did in the Chinese paper with the shunts. So we keep putting it in here and use the forceps to widen this. Here's some blood vessels. The spinal cord is here. The dura's up here. And so just like an icebreaker on Lake Michigan, we're just like breaking up the bands. And you could, and it did help some people. I think that, and this has not been accomplished, but what I'm hoping is sometime in the future, some enterprising people and technology will improve that we can reduce the invasiveness further, and somebody can come in and they have arachnoiditis, and they would, instead of getting a laminectomy, they could percutaneously, in other words, just like a spinal tap, they could have a catheter put in and they could break up some adhesions through the skin and they could go home that night. But we're not there with technology yet. The scopes would have to be smaller, and but you can always hope. So as far as improving treatment, as far as treatment challenge, we can't visualize all the scarred areas. We could potentially use the endoscope to open up the CSF pathways. Another way to do it would be to bypass the scar, to get the spinal fluid around the scar, and then around surgery, if we had better anti-inflammatory, anti-fibrosis medication, that might prevent recurrent inflammation and scarring. And hopefully we could have a clinical trial and look at some of these things and see how the people did before and after in a very organized way, and really be able to evaluate if a treatment is effective. Well, you can contact me if you have any questions, and can't do this alone. I did very little of it alone, most of it by the students. So thank you very much.